Namaste and greetings. I, Tanu Palewal, researcher at IMPRI, Impact and Policy Research Institute, Prabhav एवं नीति अनुसंधान संस्थान, नई दिल्ली, extend my warmest welcome to you all to IMPRI Web Policy Learning. Today marks the third day of Health Sector Management and Governance, an Indian Perspective, an online national summer school program, a one-month immersive online certificate training course. This training program is organized by IMPRI, Center for the Study of Finance and Economics, IMPRI Web Policy Learning. This program has an excellent panel of experts who will be sharing their expertise for the duration of this program. The expert panel includes Professor Mukul Ji, Mr. B. Ramakrishnan ji, Dr. Parashram Patil ji, Dr. Manorama Bakshi ji, Dr. Urvashi Prasad ji, Professor Pradeep Panda ji, Professor Sangamitra S. Acharya ji. The panel of conveners comprises of Dr. Simi Mehta ji, Dr. Arjun Kumar ji. The chair of the program is Professor Mukul ji, former professor, Lee Kuan Yew School of Public Policy, National University of Singapore, visiting distinguished professor IMPRI. Proceeding further, I welcome all the participants to this enlightening deliberation and thank you for being interested and putting your time, energy, and efforts into learning, sharing ideas, and contributing to the evolving landscape of healthcare management and governance. We have also shared the course outline and reading resources in your email. Before we start today's session, I would like to remind the housekeeping announcements once again. Please join the meeting on time. There will be question and answer session after each presentation. Share your questions on the question and answer box. The questions must not be posted as an anonymous attendee. Ensure that your questions are precise. Refrain from making general comments on the question to save time. Now, without any further delay, let us start with our program. It's my honor and privilege to invite Professor Mukul Ji, former professor, Lee Kuan Yew School of Public Policy, National University of Singapore, visiting distinguished Professor IMPRI to commence today's program. Welcome, sir.
Dhanyavad. Today is going to be fairly heavy day with a lot of material to cover. We were in the midst of talking about the analytical frameworks. So we will complete that first, then look at the introduction to economics of healthcare, and then have the panel discussion with 4 panelists. We had earlier talked about funding and financing mix, that funding is the percent of GDP society must set aside to meet the healthcare needs of the society. And the health financing mix are all these different instruments through which we can do it. And the funding is the key, but financing mix selection is also critical. We had also said that it is the government organizations, health organizations, which provide services. So we must understand the dynamics of the organization and organizational change, motivation, and other similar aspects. A lot of countries try to bring about healthcare reforms without reforming organizations, and therefore they don't get the kind of response or outcomes which they desire. We had mentioned that the word governance is widely used, but it's not always well defined. Now, what is a generic model of a health system? First, we have the users, so those who use healthcare services. We have providers, which covers a wide range. Then we have the third-party payers. In other words, the users don't always pay directly to the provider, there is a third party. If you buy an insurance, health insurance, then insurance is the third party. For Ayushman Bharat, the government is the third party. For some employer may be the third party. So there are third party is something that payers that we need to take into account. Then we have government and we have medical regulation and the medical council to oversee the development of the sector. So this is a generic model, how we manage healthcare sector. Providers and third-party payers can be in public sector or private sector. That is something that policies must choose. We talked about technical, productive, and allocative efficiency because efficiency and effectiveness outcomes are what we desire. Now, there are many governance failures in healthcare. The relationship between key stakeholders, as illustrated earlier, suffers from many governance failures. Information asymmetry. When we talk about economics of healthcare, we'll say that in this case, very simple example, if I am not feeling well, I go to the doctor. The doctor has far more information and knowledge than I do. So there is an information asymmetry. How do I know that doctor wants to act in my interest as a principal rather than in his interest as an agent? So principal agent problem is there. We'll talk about moral hazard, adverse selection, and so on. And these are ubiquitous in private sector, public sector, and so on. So a range of policy tools are needed to actively manage and overcome this failure. You can't wish them away. Okay, they are there. So you have to actively manage it. This suggests that there's a strong case for active oversight and regulation. If these government failures are allowed to manifest for a prolonged period, it would result in very high out-of-pocket spending. Now, out-of-pocket spending creates a lot of distress to the households because a bad episode of health incidents, if you have to pay out of pocket, it could very adversely affect household finances and people could get into poverty. Healthcare is marked by both government and market failure. So market failure is information asymmetry, moral hazard. Moral hazard is that people have an incentive to behave in an inefficient way. If third party is paying my share, or if I already have a health insurance, sometimes I am negligent of my health, thinking that, oh, insurance company or government will cover me anyway. Adverse selection, wrong people get selected for a program. And cream skimming and dumping. So what happens is in many government programs, private sector would try to avoid them because they are relatively poor and have high demands. They will pass it on to the municipal hospitals, while private sector would want high income, less demanding, with good insurance patients. So they are cream scheming this and dumping the patients to the municipality. Government failure, again, information asymmetry, moral hazard, vested interest, limited policy capacity of the government. Now, very few healthcare specialists in India, we didn't recognize. We always thought of healthcare as a welfare measure, not as a professional measure, as I've repeatedly said. So policy capacity must be increased very consciously. And we're trying to do that now. Vested interest. So a lot of vested interest, whether it is multinational pharmaceutical companies that don't want Ayurveda or Ayush or low cost generic drugs to be used, or is it uh, entrenched hospitals that do not want reform, that would reduce their cost and accountability and profitability, and so on. So political economy is integral to the what we need to address. So governance failure, information governance, information advantage, moral hazard, opportunity to misuse information. Then you have limited restrictions on provider behavior caused by inadequate oversight by third-party players or the state. And the final incidence of expenditure shifted to the individual who is the weakest stakeholder. So third-party players can restrict the monetary value of coverage. We all have heard anecdotal stories as well, but research also suggests that the insurance companies don't always pay up in turn in the way that uh, uh, is contractually mandated. Overcoming these failures will require realigning incentives. That's part of the economics. The key stakeholder phase and ensure that each of them achieves their core purpose. None of them are incentivized to accomplish this. So third-party insurance, pool healthcare risk, underwrite financial contract, purchase healthcare services on behalf of users at competitive prices. This is what Jan Aushadhi does. All the Jan Aushadhi stores, why they are cheaper is government is using its buying power through these stores to buy in bulk and ensure quality that allows them to procure at a cheaper price, particularly the generic drugs. Monitor and enforce contracts. So the insurance, like IRDA, insurance regulatory agents, must make sure that they do monitor and ensure the contracts with providers. With provider, deliver healthcare services at competitive prices and not misuse information advantage, and moderate access to non-essential services. Now, in any healthcare system, doctor is the and specialists are the captain of the ship. So you don't allow access to them very quickly. You can't walk in and say, I want to see specialists. In India, that is possible. So in every country, they have a filtering process. You need reference from general practitioner, others, to be able to see specialists. So, and the non-essential type of services too, you can moderate access to it. Users contribute towards prepayment for healthcare services, moderate demand for non-essential services. So this is how we can tackle. This will require a system of countervailing incentives and disincentives to shape their economic behavior. Incentivizing cost-effective responses while disincentivizing any propensity to engage in maleficent behavior. Importantly, it will require recasting the generic model with the government at the helm, steering the sector to reconcile conflicting goals through an orchestrated use of policy tools. Healthcare is an area which cannot be left to the market. Government must orchestrate it. You can use market tools, can use private players and you can use incentives, disincentives, but government must orchestrate these. Idealize government use of policy tools. Government need to reconcile the conflicting goals of users, providers, and third-party payers. So this is where government's role comes in using the tools. Now, what are the concerted and coordinated tools? Organizational. Take on the role of provider, third party. Can exert monopoly as a provider, monopsony as a purchasing power. So Jan Aushadhi does. Reduces ability, or many hospitals, government hospitals, should be buying in bulk and using their purchasing power to drive down cost. Now, because in India, healthcare is a state subject, many states don't have high-level capabilities to be able to do that, but they should. Reduces ability of providers to exploit its physician agency and overcome adverse selection. So wrong people don't get the benefits. Informational, reduce asymmetries of information. That's why we have to have very strict rules on, for example, when you buy food items, there's a labeling behind. It says expiry date, use by, and all that. But it also has ingredients, which is in the descending order of importance. So all that is part of the reducing asymmetric information. Government can provide cost of treatment standard of different procedures in different hospitals. They can put that on the website, they can require it, reduces information asymmetry. Fiscal, moderates excess and demand, and reduces the malfeasance associated with moral hazard, where wrong incentives to use too much of healthcare. Now, we can do regulatory part two. The mandate individuals to be enrolled in a health plan instead of voluntary, separate prescription and dispensing functions, ration access to advanced healthcare services through gatekeeping, utilization reviews, require providers to monitor cost of treatment, make them available to the public. And even many government agencies like Employee State Insurance Corporation, their hospitals don't make this information available. They should. That's part of the reforms. Information, make information available, waiting times, clinical outcomes, formulary available to provide, and third party. And organizational, underwrite the financial agreement between users and providers, provide healthcare services through publicly owned hospitals. But the hospitals have to have credibility and trust. If they don't, if people don't have trust in municipal hospitals, even a poor private hospitals can get a lot of monopoly power and can charge high rates. So all of us have a stake in good municipal hospitals. And sometimes it is quite surprising that people don't protest, don't demand good schools, quality schools, good healthcare facilities, others, and so on. Instead, they just demand freebies and this and that. But freebies, as we said, cannot change these governance issues. They're not these are which are inherent in healthcare. And that's where an alert and informed public can provide this. So we have provided some analytical framework. The underlying premise is that the health sector needs to be governed and managed well, with focus on health outcomes and not just on health expenditure. The key trade-offs in the health sector involve accessibility. You have to be accessible, affordable, individual, employer, fiscal, economic, technological, organizational competence, adaptability, and minimizing total resource cost funding. There are trade-offs. We must understand them and accept them. It should be stressed that frameworks and tools are not blueprints. They are an aid to thinking about strategies, policies, and specific measures. So discussion in this session once again underlines the complexity of managing healthcare systems, setting up organizations and procedures for generating timely, good quality, and relevant data. India needs a large pool of health policy and health system management specialists who can research at the state and local levels as well. Dhanyavad. So that would complete our discussion on the healthcare analytical frameworks. Anybody has any questions or comments?
Thank you so much, sir, for your session. And we are very grateful to you. So the floor is now open for the questions. Any questions? Okay. Uh, Next we'll continue.
Okay. So let me, is there a question here?
Yes, there's one question.
Can somebody
So
speak that?
Yes, sir. Lakshmi KG was not able to clearly understand the analytical frameworks.
I mean, I'm not sure how to address this.
Am I audible,
Yeah,
Professor?
you're audible.
Yes, hello.
Let's discuss this a bit further.
Right. Yeah, thank you so much for the presentation. But so you did discuss certain terminologies and certain concepts, but I'm still not getting a sense of what are the analytical frameworks that we can use to think about this whole system.
No,
I'm really sorry if I've missed something that you've already discussed, but I just seem to have got a sense that you've gone over concepts, but not really analytical frameworks. So could you please just say something more about that?
yeah,
Thank you.
sure. I'd be happy to. Let me see. Let me share the screen. Okay. Think. No, this has gone out. Okay, Lakshmi, we talked about the overall model. We have a users, as consumers of healthcare. We have providers. Then we have a third party payers of that. Now, and then there is government to regulate, and there has to be some medical council or something to oversee the production of healthcare personnel, education, and others. So that is a framework where you have got users, providers, third party, government, regulation, and an overseer. Now, that framework has to address the various types of market failures and government failures. So we talked about the market where market may fail, where government may fail. the reasons for it. We suggested some of the ways you can address it. So that triangle that we had is really the standard framework used in the healthcare literature. Does that answer your question? And then specific policies in a particular context and what is a particular problem in healthcare sector, then you have to adapt that to it. Does that answer, Lakshmi? Hello?
Professor Asher, if I may be permitted to add something.
Yes,
Of course,
Thank
it
you,
would be
Professor.
most welcome.
Thank you. So it has been very nicely provided. The information has been very nicely provided regarding all the aspects of the healthcare sector governance. And in that, I would like to add that we have got a National Health Authority.
Yes.
So they are the organization who are actually trying to bringing the overall governance of all the three types of stakeholders, major stakeholders that we have just mentioned: the third-party payers, the users, the providers, and the government regulatory authorities, including the National Medical Council, as well as the other councils, allied health councils, and okay, can I continue? Am I audible? I think
Yes, you are audible, please.
Okay, thank you. So the Allied Health Council itself is a conglomerate of around 52 different types of cadres, and they are all very much stakeholders. So we have got multiple specialties. There's each one of them are stakeholders, and the National Health Authority also impanels the hospitals. They try to fix up the rates of each individual procedures, and whatever you have just mentioned, Professor Asher, Dr. Lakshmi, you might be agreeing and you might be understanding. So it is a very complex economic as well as socioeconomic and a medical issue. So they have to be looked into in totality, and certainly it will take time for us to immerse into it and understand how it is progressing and how it will be further unfolding in the years and decades to come. So I would be brief, and up to that I would end here. Thank you.
Thank you, Professor Ranjan Das. Very helpful.
Good evening.
Good evening.
Very good evening.
Good evening, ma'am.
Good evening, Professor Asher.
Good evening. Nice to see you.
Sir, are you taking the session now so I can reintroduce?
Yeah, we have the session on Introduction to Economics, right?
Yes,
Of
sir.
healthcare. Yeah.
Okay.
Yeah, because the panel discussion will come after the economics of healthcare. Is that all right,
Yes,
Dr. Bakshi? Is that okay?
Perfectly all right, sir.
Yeah. Okay.
Perfectly all right.
Thank you.
Okay.
Thank you.
So,
So let
okay,
me
so
get
let's
to
move.
the. Sorry, go ahead. Go ahead.
Okay. So it's my honor and privilege to invite Professor Mukul Asherji, former professor, Lee Kuan Yew School of Public Policy, National University of Singapore, visiting distinguished Professor IMPRI, to commence his next session of today's program.
Okay. Now, Lakshmi was asking about the frameworks. The frameworks that we talked about in the earlier session is broad. And as I said, it is not a blueprint. It is an aid to thinking. An important part, as Professor Das mentioned, is the economics. of and the economic reasoning in the healthcare sector, which has not received as much attention earlier. And we are beginning to get into it. So what I thought was I'll just provide you with some introduction to the economics of the healthcare sector. So introduction, selected economic concepts, pharmaceutical policy, because medicines are very, very critical, and more cost is being devoted to medicines. The COVID-19 brought out very clearly the high cost of medicines that we have to pay. And concluding remarks. The origins of health economics are usually traced to two seminal contributions. One was Kenneth Arrow's 1963 paper. Notice how recent health economics is as a subdiscipline. Uncertainty and the welfare economics of medical care in American Economic Review. It has shaped the way health economists think about the market for healthcare, because this is uncertainty and applying to welfare economics. Michael Grossman's 1972 paper on the concept of health capital and the demand for health in Journal of Political Economy, on the other hand, laid the foundations of the influential health capital model. Healthy population is an asset, it's a capital good. A population with high burden, disease burden, can reduce growth and can create other issues as well. But the history of health economics goes further than that. Economists, social researchers, epidemiologists, and others have analyzed topics at the intersection of medicine and economics. So how to organize health insurance, for example, or how to calculate the value of life. In courts always have to make judgments about how much award to give for somebody gets injured in a car accident, how much compensation to pay. It will involve health economics. Or how to calculate value of life, the context of cost-benefit analysis. Many of these issues have not received much attention by historians of economic thought. Health economics is an applied field of study that examines and finds system-based solutions to make healthcare more equitable, accessible, and affordable. So this is common. You want access, you want affordability, you want fairness. But there are trade-offs that we have to recognize. They are inherent. Health economists seek to understand the role that a broad range of stakeholders, again, notice in the framework part coming in, healthcare providers, patients, insurance companies, the third party, government agencies, the third party, corporations, public organizations, play in healthcare spending. Health economics seeks to examine the factors that influence the industry cost and quality of care. So hospitals are like any other firm, and we have to analyze their behavior, their incentive structures, and so on. You know, there was a very nice American TV serial quite a few years ago. Professor Das may remember this. It was called Chicago Hope. And the other one was called ER, Emergency Room. And there was a constant conflict between the sort of MBAs, finance guys who were running the hospital and the doctor who wanted to provide the best care. So that created a lot of human tension, and those two serials brought this out very, very well. I suggest for some of you to go back, and you will get a lot of insights after this program into what the health industry, how it operates. How do patients, healthcare providers, insurance companies, government influence how healthcare is distributed, and in what ways can it be improved. So health economics also involves examining firm or provider behavior and relevant industry structure, such as for pharmaceuticals. Now, one fact about pharma industry is we know it's an oligopolistic industry. Globally, only few firms. Oligo means few in Greek. So oligopoly. Monopoly means one. Oligo means few. So there are few multinational pharmaceuticals, and data show that over decades, they have had much higher profitability, rates of return, than what would be attained by a more competitive market structure. So those are well known. And so pharma is a big political power. It has got big influence on this. And the one reason for generic drugs, which are much cheaper, not very much, are not used as much as they should, is the power of the pharma industry. So political economy is also a part of it. Health economics is important because it focuses on how the economic behavior of stakeholders and recipients affect the quality and cost of medical care. It includes how people pay for care, how these payments are processed, how health systems around the world can be restructured and improved. Tackling any systemic issue at the root cause can alleviate some of the problems from arising again. This I got from Coursera, which is where you can get a lot of free courses, and they're a very nice set of notes on health economics. Health economists study what affects health outcomes. They ask such question is, how do we put a value on health? What factors influence health besides healthcare? What influence the supply and demand for healthcare? Behaviors of healthcare providers versus those seeking care. The providers have a profit motive often, or they don't have much incentive because they may be government hospital where job security is there. There is not much technological upgradation, not much accounting, sophisticated management information, accounting, and so on, while those seeking care want to minimize cost to them. What are some alternative approaches to healthcare production and delivery? How can we improve the ways in which we plan, budget, and monitor healthcare? So again, this is from Coursera, and I suggest that you go to that website. Taking the concept of payment reform as an example, doctors can be compensated in different ways than traditionally existed. In recent years, value-based care models, such as episode-based payment, fee-for-service, population-based payment model, are contributing to more equitable healthcare. I can't go into very great details on this. Payment reform affects healthcare providers, insurance companies, and patients. But let me give you an example. Suppose the health ministry says to the hospital, we will reimburse you for every night a patient spends in your hospital in hospital bed. Okay, that's the payment system. What do you expect the hospitals would do? They will lengthen the patient's healthcare treatment so the patient stays for longer days and they get more money. So you have to understand incentives, how you structure it. Or if you say to the panel doctor, a company appoints a panel doctor, says we'll only give you very small amount per visit of our employee. What will that panel doctor do? They will ask for more visits. So the more visits, the more the panel doctor does. So people who don't understand economic incentives and so on, many times they design these systems and they can be improved. Healthcare economics can be approached from 6 key areas. How much spending growth can be afforded? Role of patient, role of healthcare provider, risk and insurance. See, risk is something that can be insured. Why? Because the probabilities are known. Uncertainty, we do not know the probability, so you cannot insure uncertainty. You have to manage it. But so long as you can calculate risk, probabilities of an event occurring, you can devise insurance products. Benefit design, I just mentioned. How do you provide benefits? And payments. Sorry, payments is the one that I had indicated. We come back to the generic model. If Dr. Lakshmi is listening, third-party payers, users, providers, government, regulation, and medical council. And Professor Das has explained the Indian context for that. That's our framework. And how do we manage this framework in a particular context? Now, one of the more famous health economists is Victor Fuchs. In 2011, he wrote a book, Who Shall Live? Health, Economics, and Social Choice. This is an outstanding book on the multidimensional nature of choices made in health policy and the inherent trade-offs and opportunity cost involved in decision to interfere with the healthcare market. Far too many policymakers fail to consider the complexity of healthcare in their decisions and take, as Fuchs labels it, a monotechnic approach to the issues. So this book, somebody's opinion, must read, who wants to be a serious student of health economics and policy. So I suggest those who want to go further, do look up Fuchs' book. It might be even on the net free, or it will be a very minor cost by now. What are the select economic concepts? Agency theory, moral hazard, economic role of insurance, adverse selection, and asymmetric information. So principal agent issues occur in both public and private. We as principal have to get work done through an agent. If I am sick, I go to the doctor. Doctor is my agent. I am the principal. How do I know doctor will act in my interest rather than in his or her interest? That's a principal agent. You cannot wish it away. You have to manage it. Okay, I can't go too detailed into this given the time limit that we have. So in private sector, principal agent occurs separation of ownership. So managers run the corporation, owners don't. So how do owners know that managers will act in their interest rather than managers' own interest? It's a huge problem in the corporate sector. So information monitoring, organizational arrangements for checks and balances are essential. Quality of organizations and institutions matter. But you never hear these issues discussed in the healthcare policy. Even at the center, let alone at the state level, where health in India is a state subject, not a center subject. Moral hazard, all the contracts involve expectations about future behavior. If one party in the contract cannot monitor the other party's adherence to it, one or both the parties may engage in post-contract opportunistic behavior to secure advantage, utility, or profit. In general, moral hazard occurs when the party to be insured can affect the probability or magnitude of the event that triggers payment. Many times there are also malpractices. I have personal experience. I would have a car insurance. My car gets into some minor accident. I go to the repair shop. The repair shop will try to goad me into saying that why don't you declare this was wrong, it was major, inflate the bill, and get all the other things done. Now that would be cheating the insurance company. And there is a lot of, because this is moralizing. And people who are honest will not do it, but many people would do it. So this is an issue we need to consider. And I've given you the examples. In healthcare, moral hazard represents misallocation of resources caused by a particular method of financing healthcare. When medical expenses are paid by a third party, employer or insurance company, individual and his or her healthcare providers have less incentive, just like my car accident. Insurance company will pay, but ultimately my insurance premium will go up if I behave. And if a lot of people behave according to what the garage owner who wants to make more money, if we accept their what they are saying. Okay, I won't go into the economics of it. You can look at it. How do you deal with it? Make fixed payment to the insured party. So these are called diagnostic related payments. And you have a detailed list. If this is the one, this is what they will pay as a third party. Co-insurance, you have to pay a little bit yourself, then you are careful. Deductible. If I buy car insurance, I'll have maximum deductible because I don't want to go to insurance company for minimum small accidents because their administrative costs remain the same. If the damage is 20,000 rupees or 5 lakh rupees, I don't want 20,000 to bother to them. And put yearly and lifetime limits. So these are the ways to deal with it. So individuals are risk averse, which means that person prefers to bear a given cost with certainty rather than an uncertain prospect of a greater cost with the same expected value. So this is what the insurance does. When you buy insurance, whether the event occurs or event doesn't occur, you have paid the cost of purchasing insurance, which means smoothing out your wealth. And that is the main role of insurance, is to smoothen out wealth. A lot of my relatives, friends will tell me, you keep on telling us to buy medical insurance, but we haven't gotten sick in 3 years. So I say, let's go to the temple, let's do puja, that you are not sick. But what have you bought? In case you had gotten sick, insurance company, you had smoothened out your wealth. You would have paid. The best example is a life insurance. It should be called death insurance because you get paid only when you die. So every time you buy life insurance and you don't have to collect, means you are alive. So think, okay, it's not a cost. People must understand what the insurance is. You are buying wealth smoothing. That's the product. And it is very good to buy that wealth smoothing product. I won't go into utility of money, other things. There are adverse selection. So why do elderly like me have difficulty buying medical insurance outside? Because an older person is almost sure to collect. Why would I, as an insurance company, give you insurance if you are sure to collect? Or my premium will be very, very high. Okay. So that's an adverse selection. And somebody then will have to address this issue. Usually it's the governments that insure the older people. Okay. Asymmetric information, I already said about patient and doctor. Pharmaceutical policy. The issues surrounding intellectual property and production and cost, major contention in WTO. Formulary policy surrounding which drugs and treatment can or should be included in the benefits package. Technology assessment. We haven't been doing good technology assessments of the medicines, which are needed, which should be there, which should not be there, which technology are not. So health technology assessment is a systematic and multidisciplinary evaluation of the properties of health technology and interventions covering both their direct and indirect consequences. You can see how critical it is. Even today, people are debating whether Pfizer's vaccine for COVID-19 was effective. Okay, so that HTA we need to be a lot more proficient in. So concluding remark, this was very brief overall introduction to health economics. It is a subject by itself. In good public policy schools, health economics and management will be at least one course, if not two. So health economics as a subdiscipline is around 70 years old. This session has explained the nature of this subdiscipline, including key economic concepts. This applies to all types of medical system, including Ayurveda. So we are beginning to see, for example, that in Ayurveda, we need systematic modern research to increase the trust in Ayurveda product. So some companies like Himalaya from Bangalore, which have been able to generate that trust, their products command premium prices. I go to Singapore stores and get Himalaya products. I pay more than the Western companies' products and so on. And I buy it because I have trust in Himalaya. Okay. And so we need that modern testing, others, and so on. And all these economics apply to them as well. So I'm glad some more Ayurveda corporations like Patanjali, Dabur, Himalaya, others are coming up, which are managed with modern management techniques and technology. But a lot of the health policy and management remains contextual, and understanding of local conditions is essential. This is what the, lakh dukon ki ek dawa hai. It doesn't do it. You have to have contextualization of the healthcare, and that requires deep local expertise. That's why state, local level is going to be very critical. Understanding human body and its function should be included in the school curriculum. Very few people know. One time I went to there's an international yoga festival in Uttarakhand and in Rishikesh. So 4 or 5 years ago, I went there for one. And one of the takeaways I got in participating is how to breathe. Do you breathe shallow breathing or deep breathing? And how much difference there is. We don't know our body. Schools don't teach us, others don't teach us. And how do we move from the curative to preventive care if we don't understand our human body? So I think this is a lesson for all of us. Understanding human body, it's never too late. A lot of information is available, and that would help in managing one's own household health expenditure and health care as well. Okay, thank you very much for this opportunity to share few remarks on healthcare economics. I realize they are inadequate, very basic. Maybe Professor Das could add some more aspects to it. Please, Dr. Das, Professor Das.
Thank you, Professor Asher. So it was very interesting, and the way that you presented was wonderful, sir.
Thank you.
Sir, a couple of points I would like to add. You have very nicely stated regarding the health technology assessment. As of now, the modern science has a method of doing scientific evaluations, and we have got cross-sectional studies and various other types of studies. At the apex is the randomized controlled trials,
Yes.
RCTs. But all this is being done only by the medical sector. All persons who will be associated with the trial, except for the institutional ethics committee, there we may have a couple of members who are non-medicals from the community, from the laypersons. But what you mentioned is systematic and multidisciplinary evaluation. This is a golden word that the medical fraternity should think of, and we need to incorporate it. Without that, sir, we will not be able to either have the trust of the society, because as you have already mentioned, and as it is everybody knows it, that the pharmaceutical industry as well as the healthcare industry is entirely dictated by political and commercial considerations. So if we want to really go beyond the clutches of the political as well as the commercial and the industrial considerations, what we require is the systematic and multidisciplinary evaluation by broad-based agencies, not just from the pharmaceutical or the industry. That was one point. I would certainly agree with you, and we would be certainly looking forward to that. How do we do it? And the second point that I would like to mention was regarding, you mentioned about the cost benefit analysis and the cost effectiveness of technologies. That point is very, very important, sir. Each of the technologies that we as on date follow and believe that they are most effective, many of them would not stand up to the scientific methodologies even that we have from the medical and the pharmaceutical industry sector. Sir, here I would like to give a very small example. There's a very important, crucial book by one of the leading medical teachers of the US, and the book is known as the Emperor of All Maladies. It speaks about cancer and about various other standard common problems that we have, including cancers. And it has been shown very clearly through accepted means of medical science that many of the systems that we follow for their treatment, maybe the radical cervical dissection that we have for cancers and many other, including for breast cancers, it has been shown very clearly. But although the mainstream medicine has not yet accepted those proposals or hypotheses, but we have to open ourselves up and introspect that whether these are really effective, cost effective, and really providing us the quality of life that we expect at the end. So that was the only two observations that I would like to make. And thank you very much and for everyone for giving me this opportunity to speak. Thank you, sir. Thank you, Professor Ashar. Back to the organizers.
Thank you so much, Ranjan sir. And thank you so much, Mukul sir, for such a comprehensive presentation and a detailed session. Now, I would like to invite everybody for the panel discussion.
Now, can we have some Q&A for before we go
Yeah,
to the
sure. So the floor is now open for the questions. You can either put the questions in the Q&A box or raise your hand. Yes. Okay, Ashlesha ji, you can go ahead. हेलो अश्लेषा जी।
This government insurance scheme in Maharashtra, Mahatma Jyotirao Phule Jan Arogya Yojana, and also PMJAY, which is now the largest national or government-run insurance scheme in the world. So recently, Mahatma Jyotirao Phule Jan Arogya Yojana, they have now, so previously it was for selected sectors, the lower socio-economic sectors. But just a few days prior, the government has now opened the scheme for all the citizens, irrespective of their socio-economic. Now, in such situations, how does the health economy work? And how is it really sustainable in that situation?
It's a very, very important and insightful observation. We don't know how much studies were done, what sort of economic reasoning was applied before such a step was taken. If you can send me the details of that scheme and the announcement, I would be grateful. But the implications are that when you suddenly expand, will you have enough supply? Supply of doctors, hospitals, nurses, medicines, everything, because demand will increase quite a bit because of moral hazard. People will medicalize their problems, go there because it is available at zero cost to them. So demand will increase. Supply cannot be increased very fast. We'll have medical inflation. We'll have fiscal liabilities, which will have to be made up by some other type of revenue generation. So if I understand what you just said, that it just got expanded to everybody suddenly, that doesn't seem to be a scheme which has been, that increment which has been well thought out. But that's the basis of what you just told me.
I think Dr. Bakshi, madam would like to add. Yes, I'm listening, madam.
Please, yeah.
Thank you, Professor Asha, for your words, and thank you, Ashleela ji, for raising this very pertinent, pertinent question. The question is that Ayushman Bharat PM Pradhan Mantri Jan Arogya Yojana, which was later culminated into the Ayushman Bharat Yojana, 5 lakh rupees each family. Firstly, it was introduced for a couple of segments of the lower economic strata, but there are states like Jammu and Kashmir state, they have given the Ayushman Bharat Yojana to everyone, all the citizens. You have shared the example of Maharashtra, wherein they have introduced the policy to whole of the Maharashtra. So there are multiple states. But if you will actually look into the case studies, the success stories of these Ayushman Bharat Yojana, and they have a case studies also every year, even though the 5 lakh rupees is given to the, per family per year. But if you, per family per year. So suppose, for example, in a family, if somebody has, there are benefit packages which are around 1,300 in total, what we call health benefit package, and they are named 1, 2, 3. That is the how they are put it together. So suppose that health benefit package is in one, suppose somebody has a ischemic stroke, brain stroke, what we call, therein they have recently included that 5 lakh rupees per family. And suppose that 5 lakh has gone over, and next year the mother has something else, again that 5 lakhs will be given to that family. But now the question is that when I was randomly going through that, coffee table book that was there on the table of NHA, I saw that most of the treatments were around, you can say 30 to 40,000. Like there was
30,000 to 40,000
there was
around.
Yeah, there was something to do with anemia, and they have given multiple doses of the iron sucrose, or there were some cases of wherein there was an issue of the lady with very, very minor cataract issues. So utna ho gaya, but not many cases of, very high-ended medical treatments. And I remember recently there was a seminar of NHA wherein Basant Garg ji, he said that in fact we have saved the money. He said we had earmarked X amount of money for this scheme from this to this year. There was a saving. And to that question, I said, sir, even though you are giving your upper end mark for, higher diseases like high-end cancers or strokes or cardiovascular diseases or those kind, wherein 5 lakh is there. I said, sir, but not many of such diseases have come under, what is being there in the coffee table book. So yeah, on those packages. So we need to look deeper into like how many of these packages and those kind of things needs to be looked further. Yeah.
Right. That's really kind of you, madam. That's a great insight that you actually gave. Thank you so much. I hope if we get some more material on this, I am sure there is a lot on NHA website, but then if there are some studies, something like that, I would really love to go through. Thank you so much. Dhanyavad, sir. Dhanyavad, madam.
Thank you so much, ma'am. And
Anybody else?
yeah, Neena ji wanted to say something. Neena ji, would you like to ask? Okay, so now I would like to invite Manorama ma'am for the panel discussion. Ma'am, you're on mute.
Thank you so much, Tanu. I will try to share the presentation, and in case I won't be able to share, then you have to help me out.
Ma'am, should I share your presentation?
You have the latest one?
Yes, ma'am. Let me just check if I have the latest one.
Yeah, I had shared it today.
Yes, ma'am. Presenting.
Perfect. Thank you so much, Tanu. With the permission of chair, I will be speaking on the topic challenges in enhancing India as a global regional medical tourism. Second, but before I'll be talking about the challenges, I'll be giving some overview about medical value tourism. What we don't call it medical tourism, we call it medical value tourism because this is something that adds value to the patient whosoever comes to the destination country. And along with value, as Dr. Asher has said, it brings the economics, it brings the money to that destination country. So that is why we call it medical value tourism. And when talking about the medical value tourism, normally you will see that medical tourism is divided into two things. One is, health and wellness. Normally people think that it is the one thing only, health and wellness and medical tourism, they are the one, but they are not the one. Health and wellness is a different component. However, it also comes under the medical, our arching ambit of medical tourism. So we have the medical treatments, what we call the curative treatments, wherein like a lot of surgeries, organ transplants, right from cataract to cardiac surgery, everything comes under that. Second, we have the wellness. In wellness, normally what we talk about, the purpose is to look into the physical, mental, social, environmental health of a person, overall holistic, what we talk about. That's about the regeneration, that's about the increasing your, lifespan, that's about the prevention. And then in India, we have the alternative cures, we have the Unani, we have the Siddha, we have the yoga, we have the naturopathy. But when we talk about medical tourism, it's not just that it has just initiated a couple of decades back. Medical tourism in India was right from Charaka. And it is shown that people used to travel and go to different places to take baths in, hot springs. That was the kind of like people used to travel. what we call, there are different kinds of, whether we are having the inbound tourism, we are having the outbound tourism, or the domestic tourism. These are the different components. And it was like during the Mughals, and then later on, during the Britishers has introduced the allopathic, kind of medicines to India. But prior to that, we had Ayurveda and yoga, and those were the things, even though that has taken a backseat when Britishers came into, more of allopathy came into the vogue, then forwarding that. Next slide, please. Next slide, please. Am I audible?
Yes, ma'am, you
Yes,
are.
Yes, madam.
Next slide. Can you change my slide, Tanu? I hope you're not able to change my, okay, yeah. So when we talk about the global overview of the tourism, as per the different data sources, there have been multiple data sources. Not many countries had the exact data. So whatever I have put in here, that has been through the, particular country's official website, government of Philippines, government of Malaysia, government of India, strategy document of India, where from I have quoted these medical association tourism, World Economic Forum. As per the World Economic Forum data, before COVID, it was envisaged that the total global health medical tourism would be $100 billion. And the growth was from 15% to 25%, it would go up. However, currently in 2023, post-COVID, the world is at the travel market is at USD 60 to 80 billion, with 14 million people traveling across the borders. And the key destinations are like Mexico, Thailand, Singapore, India, Brazil, Turkey. Next slide, please. So what I will be now talking more about, I'll be talking more about the countries, even though they're very small. Like, for example, Thailand, we are talking about, or we are talking about, let's say about the Malaysia. These are the Southeast Asian countries, India. So what is it that Thailand has got 25, lakh people? And what is it that why America, even though it is number one when it comes to having the device market, having the pharma market, and having the latest technologies, but still not much of the medical travel. So the reason is that the high-end cost, the extremely exorbitant medical care cost in America. In fact, recently you might have gone through Times of India report wherein it was shown that people there are ready to sell their houses, even though because the insurance is not also enough. And that forced us to think like we are talking about the Indian healthcare. But in America, like people are forced to sell their properties and assets for their healthcare cost because the insurance is not meeting their healthcare expenses enough. That's why they are traveling either to Mexico, which is a little less, almost 1/3 of what America is costing them for the treatments. And when it comes to the Thailand, Malaysia, they are a bit higher on the higher notch as compared to India in offering the treatments in, economic treatments. But definitely we'll be talking more in coming slides on that. And India definitely prior to COVID, we had almost what we call 0.7 million or 7 lakh people who had traveled to India. And this is only about the medical tourism we are talking about. Next slide, please. Here is an overview of medical tourism, and this is based on CII and McKinsey report, which has shown that in 2016, we had 4.3 lakh people, especially coming for medical tourism. I'm not counting the wellness tourism because that is a bit different component, wherein we had much higher percentage in 2017. And then that was costing around 5 to 6 billion. Now talking about the high income country tourists coming in, something I think that we need to work on that level. Like today, if we have seen that as per the medical tourism index post-COVID, right from 7th place, we have gone up to 10th place post-COVID, based on the 46 destinations, medical tourist destinations as per the Medical Tourist Association. And when it comes to the maximum people who come to India are people from Bangladesh, Afghanistan, Iraq, Maldives, Oman, then a bit of Kyrgyzstan, Kazakhstan. These are some kind of like, and few of the African countries who are coming to India, but not many of them like from Europe and America. Not many of them are coming to India. So when it comes to the Ayush is altogether a different, very strong segment that India can push very strongly. We can push yoga and Ayush because that is something that is originated from India. And definitely the current government regime is actually putting in a lot of resources there. And India was on 7th position in 2017 when it comes to the wellness tourism, and almost $16 billion were got through wellness component in 2017 prior to the 2020. Post 20, we did not have much of data. Next slide, please. Now, in among us, the Southeast Asia, firstly, I gave you the overall global view with a few of the countries who were doing well. But among the Southeast Asia, these are the kind of treatments that people normally go for. And I have also mentioned the source, why from the sources. Like, for example, in case of India, it is from the strategy book of the Ministry of Tourism and McKinsey report. Same way for different countries, we have taken their Ministry of Tourism reports. So when we talk about India, it is number 3rd in Southeast Asia. Thailand being such a small country, but irrespective of that, they are having almost more than triple the kind of, they are getting the tourists as compared to India, and more than triple size. And when we talk about Malaysia as well, they are getting almost, you can say, double than our size of the tourists. And even though the services and the treatments are almost same, right from cardiac surgery. Yes, Thailand has a bit of more on cosmetic front. A lot of cosmetic surgeries are happening in Thailand. Next slide, please. These are some of the treatments that one is organ transplant, a lot of, from Saudi Arabia and Oman and Southeast Asia. Some of the countries, they are coming for organ transplant. And the Ministry of Tourism has actually asked for, they have eased out, visa systems. E-visa is now offered to almost 150 countries. But when it comes to the organ transplant, it's not, e-visa is not applicable to that. They may have to undergo certain formulations, certain more forms they have to fill in. Rest, these are some of the treatments I have put in there. There are a list of almost 200 treatments that normally all the private hospitals, normally these travel tourists, those who come to India for treatment, they are not going to the medical facilities of the government, public health facilities. Majorly, they are going to the private facilities. That includes the Fortis, Apollo, Dhirubhai Ambani Hospital. And if anyone has gone to Dhirubhai Ambani Hospital, it's more than a 5-star hotel, wherein you have the saloons also. People can go to, like, after their surgeries and all that, they can go to saloons. That kind of, the treatment is, and their positioning, they have kept it there. Next slide, please. This is the percentage share. I think that a lot depends upon their, different countries, their agreements with different countries. We had, land border agreements with, free visa agreements with a lot of countries, which has resulted into the agreement with Bangladesh. Following that, in 2019, we had almost 54% of the tourists coming from Bangladesh. And this pie chart is actually showing the percentage of the tourists coming in India in 2019. Next, please. Now, this is something, again, I would like to talk a bit about it. Now, you can see here, this is all about economics, what Professor Asher was saying. You can see a heart bypass. These are about 2021 rates. And this tourism ranking and average cost has been actually, I have derived it from the research of the MediConnect. And MediConnect have done this research, and there was a paper which was published, and based on that, I have taken it. Hard by pass in India is costing around $5,200, while as if you will see it in US, it is almost $1,44,000. So you can imagine the kind of cost effectiveness when a person travels here, not only the ticket costs, stay costs, accommodation costs, but they will be saving a lot of money when they come to India. When we look at Thailand, definitely like Thailand or Malaysia, Malaysia's latest data was not available, but that data is based on 2019. When we compare it with Thailand or Malaysia, which are again in Southeast Asia, our competitors, their cost is almost, you can say, double or triple in some of their diseases, and in some of them, it is almost at par with India. For example, when we are talking about the hip replacement, Thailand is also offering almost the same. So then what is it that Thailand is getting more tourists than India? So where we have to work more? What are the challenges? Why people don't come to India? What are the actual challenges? So we have to look into those kind of factors, like that why, irrespective of having almost a lot of, having either less or at par with Thailand and Malaysia, and rather in most of the cases less, almost 1/3 of Malaysia and Thailand, why do we not have that kind of load of the tourists coming into here? And why we don't have the high income countries people coming in here? Next slide, please. Here we are talking about the SWOT analysis a bit. We are talking about, yes, we spoke about its strengths. Yes, we have the economic cost advantage that we saw in above slide. We have the skilled medical doctors. I think that is, India has been, our doctors have been rather going to USA and serving there. Almost half of USA is Indian doctors. And we have the best of the medical professionals when it comes to degrees and those who have been placed by the private sector doctors. When it comes to medical technology, definitely today we are in having the best of the medical technologies, not only medical technology, AI-enabled technology, machine learning-enabled technologies. Like today we can just have the next generation sequencing, genome sequencing in place. I mean, you just think about the technology advancement, and that is we have in India. We have the diverse treatment options. Like there are so many hospitals that after this surgery or something, they have the yoga things going on. That is for recuperation. That's for the post-operative procedures. So diagnostics are available A to Z. And then definitely fast track appointment. They don't have to wait the way people have to wait in, like in Europe and most of the European countries. Cost may not be the factor, but they're definitely waiting period is so much that people tend to go to different countries. Now, what is the weakness? Perception of healthcare quality. Around the world, generally, people feel that we are a dirty country. We are not very hygienic. We are not very clean. So that is one kind of perception that has gone along. Regulatory and bureaucratic hurdles, even though we have put in e-visas, but still in some cases it was supposed to be done in 48 hours, it takes 2 or 3 days. Or sometimes it takes 15 to 30 days for a person to get their visa. That's another thing. There are infrastructural gaps about the roads, about the hospitals, about having the uniform road tax, about having the uniformity when it comes to the cost of the care, about having the uniform pricing for the products and for the pharma products, about having the one-stop center when tourists can visit. So those things are big issues wherein like the person and the middleman take advantage of the tourists, and that is one of the biggest weakness. And second is the lack of accreditations. Like, for example, not many hospitals are JCI accredited, and people across the world are very particular about the accreditation of the facility. Like, even though like when I was in the Ministry of Tourism, I was working on HIV/AIDS. And in 2006-07, I was staying in the ministry and as a UN consultant within the ministry. And I remember that at that moment, like these kind of NABH had come in 2006, and they were talking about like, okay, now we will be having, even though it was initiated in 1998, then they were thinking that, okay, now we will have the accreditation of the hospital so that we can have the tourism policy. And since then, we have been working on the India medical tourism. And still there's lot way we have to go forward. When we talk about the opportunities, definitely opportunities come out of the problems. Growing demand of the aging populations, especially in Europe and Scandinavian countries, they are forced to come to the difference, so why not India? Technological advancement is another big opportunity wherein we are well learned, we have a lot of good engineers, so we can go ahead for that kind of thing. Then demand for wellness or alternative medicines. A lot of tourists come for Unani, Siddha, or Ayush and yoga. Then marketing and branding is something, the way we had branded Incredible India, same way we have not branded Heal India concept. So Heal in India concept, I think that needs to take off the way Incredible India campaign has taken off. So for embassies, for the tourist officers, this should be one on their priorities, like, because in case they want tourism in India, I think healthcare would be one of the very strong factors when they can invite more people. And then we have to look into the, diaspora community. India is one wherein we have a lot of people who have gone abroad, UAE, USA, and all the diaspora community. So we have to convince them to bring the people here. And when it comes to their threat, there is an intense regional competition we have already talked about Malaysia, Singapore, Thailand. Political safety and concerns are big threat. Recently, I think just a month back, we heard about a traveler being raped and how that has given the, shivers across their countries in Japan. So political safety and safety concerns, especially of the women, is something that needs to be addressed. Then international accreditation, which I said that not many hospitals are accredited. So, and we need to talk about NABH also. NABH, even though it's the accreditation, but it has not got that global approval kind of a thing. So that needs to be propagated on those print. Regulatory changes we need to look into, and exploitation by the middlemen. Those who are in between, like getting the tourists here, how they put in costs there, what measures we can have about the uniformity of pricing, and those kind of things. Next, please. Now, we just spoke about the bilateral agreements. India has almost bilateral agreements across United States, France, Malaysia, and 13 other odd nations, which I told you that bilateral agreement with Bangladesh has enabled us to have almost 54% of the tourists in 2019 from Bangladesh. So what is it that brings people here? If we have the bilateral agreements, why we can't get the people from high income industries? That we need to look into. Next, please.
Ma'am, as I proceed to the next one, I would also like to request that we have other panelists also lined up. So,
can I quickly go through it then?
Yes, ma'am. Yes.
You can run it through. Yeah, sure. So then let me come to the challenges, because I think case study Bangladesh, I have spoken. These are some of the political climate and regulatory policies which I spoke about. And these are some of the like medical value train system, like peers, patients, employees, facilitators, what we talk about. And these are the challenges. Majorly, as I spoke about the quality and perception, India being like when it comes to the poor, not very hygienic, concerns of infrastructure, how we can look into the, other standards, detrimental impacts of the quality and perception about India. Regulatory issues are a big concern that we need to look into, especially the visa procedures and having the ambassadors of Indian, tourism industry across different countries. Then competition we need to look into, infrastructure and service gap is there. Insurance we need to look into, like how we can have the portable health insurance for those people who are coming to India. And definitely then there are some of the safety issues which we already discussed. Next, please. I think the opportunities of the growth, I have already addressed it when I spoke. You can move that. So these are some of the policy recommendations. I think that we should focus on 3 market segments. One is SAARC countries, Middle East, and CIS countries, and Africa. We need to concentrate on few countries from Southeast Asia and Europe and America. These are the regions that we can focus on. We need to strengthen the bilateral agreements. We need to look into the public-private partnerships, even if we are talking about PPP in a very big way. But unfortunately, as per the Niti Aayog report, just 5% of the medical healthcare has PPP, public-private partnership. So we need to look into how we can invite the FDI investment through PPP when it comes to the health infrastructure, which already we have done with UAE, and we can have the same kind of thing procedure with other countries as well. And then visa processes, and we need to have unified body for the medical value, wherein one-stop center would be there, wherein people can get everything, pricing, who are the key hospitals, what the hospitals are offering, what are their packages, what is the transportation mechanism, everything. And we need to leverage the technology. Next, please, Tanu. Some of the short-term and mid-term, like simplify the visa procedures and medical visas, strengthening agreements, launching the target campaigns, Heal in India, and maybe something to do much better, more forcefully. Mid-term can be like medical value tourism, how we can have centralized body, how we can use the digital system for that, for having that body, how we can have interministerial coordinations with aviation, with tourism, with health, with commerce, because all of them have the indications across with because tourists are going everywhere, urban development, and how we can have transport ministry that has again a big role to play. So how we can have coordinations amongst them. And long-term actions can be inviting health infrastructure, PPP through FDI, enhance the FDI. Those kind of things can be the long-term, actions. Next, please. I think that is about the conclusion and summation of my presentation. Thank you. Thanks, Tanu. Mostly later on, I can address the questions.
Yeah, thank you so much, ma'am, for such a wonderful presentation and a great session on this topic. And we are really grateful to have you here. Next, we'll move forward. So now it's my honor to invite Mr. V. Ramakrishnan ji, Visiting Senior Fellow IMPRI, Managing Director, Organization Development, Singapore, for the session on use of AI and other technologies in health sector management and governance. A very warm welcome to you, sir.
Thank you. Nice to be back. I'll see if I can share out my slides.
Sure, sir.
Right. I'm not able to, so let's go back to the same thing. I have sent you the slides, so.
Yes, sir, I'll share.
Yeah, kindly share it on screen. Okay. Okay. Good evening. Thank you, IMPRI. Thank you, Mukul, for inviting me to be part of the panel. The outset, let me make it clear. I understand and appreciate technology, but I'm no expert on AI. What I did do for this session is I checked with a number of my classmates who have worked with AI for the last 30, 40 years. And I've checked with the managing director of the company I was a director on, where we had a fairly elegant clinical healthcare model, which is now working in Hyderabad. But for various reasons, which I will now detail from first-hand experience, hospitals were refused to consider this. Obviously, the escape route was always cost. I don't know if we can pin a cost on health, but there are other reasons for it. So that said, let me begin. Next slide, please. I think there are numerous challenges in the Indian healthcare system, which Dr. Bakshi has defined. There is a lot of misconception about AI, and I had to simplify it so that we are all on the same page. By no means is it a comprehensive definition of AI, but I will use it to highlight how healthcare can use it. Governance in the healthcare system is pathetic, to say the least, be it hospitals. I myself have gone through 14 surgeries. I've got more than 180 stitches on my body, and I have been through several hospitals, and nowhere have I seen either hygiene or governance on par with anything that I would keep at my home in the normal course of things. And how do we leverage AI for sound governance in the current status in India, and what should be the way possible? I wouldn't say way forward. The government of India is doing a lot of thinking on this, so I wouldn't like to pretend I have second guessed them. Next slide, please. Right? It is a crowded country, right? And what R.K. Lakshman said about cars is true about hospitals and clinics. And I stay in the hills in South India, and one PHC services 72 kilometers, 72 tribal villages, and there are no roads. So forget R.K. Lakshman, there are no roads. But the fact is that the healthcare in India is still very much what the train shows, massive in numbers. And there is tremendous potential to use it. And we did use it during COVID and collected a lot of information, though it's not clear what has happened with that data. Next slide, please. I always love this slide. I used it in many, many different perspectives. But to get a broad overview of the Indian system, essentially, we are opening up a lot of high quality hospitals in AIMS that addresses the quality of life, which is the green arrow on top. Whereas the bulk of the need is in the lower end area of community care, of traditional medicine sub-centers, public health centers, state and private OPD clinics. Roughly about 40 to 60% of the people still use alternate medicine. And I must say that when I had a massive skeletal-muscular injury, after 6 months of treatment, when allopathy gave up, Kalari and Unani combined to have me rid of a slip disc and was able to stand within 3 months. So I'm a first-hand beneficiary. I still do the Ayurvedic corrections for my skeletal system. This doesn't get counted, and I would say about 60% of Indian population still uses alternate medicine. There are about 2 million alternate medical practitioners and probably 5,000 hospitals and clinics in the country. But again, in terms of number of clinics per person is low. I'm personally witnessed how the public health centers, the Anganwadis, take care of in the obgyn and neonatal areas in the vaccination process. I'm also personally witness to how PPPs help the state and private OPD clinics in the Nilgiris upgrade and manage during COVID. We put in a lot of money, but we had a lot of good results as well. And this whole system does not work seamlessly. It all works in bits and pieces. And much of the data out there is not very reliable, at least as I understand it. Next slide, please. Okay. The public health system, as I have understood it, access and reach. AI can help resolve this. All those blue-starred areas, AI can help, technology can help. Low quality of care, right? You can have access to almanacs online, and the software that I developed in the company that I was assisting, we did have almanacs in very sophisticated systems for prescription comparison against symptoms and stuff like that. Poor hygiene, I think Dr. Bakshi has mentioned. Limited and poor competence and capability, I think AI can correct that. Corruption, endemic. The PHCs, for example, here, if 1 lakh is given for my monthly medication, less than 10,000 reach the center. And in the COVID, we were in a situation where we had the vaccines, but no syringes. Limited capacity, very crowded centers, rivalry with private clinics, inadequate and unreliable insurance access, inadequate access to mentally ill, terminally ill, and chronically ill patients. This is a huge thing. We've not even started addressing this. So I've just outlined where technology can help and where technology can possibly support and where it has a limited scope. Next slide, please. Right. Now, just a very quick oversight of AI basics. You have a neural network, a machine learning program. You have neural relay, the training data. You have weak AI, and you have artificial narrow intelligence. These are all terms that one can read upon. Just for comprehensive coverage. Next one, please. What matters is basically AI uses an algorithm. That's the lowest form. And this is what Amazon, Flipkart, and others use to predict, okay, here's a guy 52 years old. He's bought all this. He's now going to buy all of that and this. It's an algorithmic model which is continuously refined. And then it has got minimum layers. There are multiple layers which helps unsupervised learning. So if I link it to Aadhaar, I know this guy's age profile, I know his location, I know his travel pattern, I know this, that, and this old Google joke that when this guy wanted to buy a pizza, the pizza parlor gave him all the dope on his health condition. It feature is automatic extraction. Generative AI is deep learning, and the data from COVID can be used for generative learning, though unfortunately in the last 5 years, I don't know if they've updated it, but it is no longer valid. We should be moving to adaptive AI, machine learning, large language models, retrieval augmented learning, especially with the almanacs and prescription management, so that we overcome the deficiencies. Next slide, please. Here's a simple example. You have an input layer, you have a lot of multiple hidden layers and output layer. And the four models that I showed you, the multiple hidden layer gets more and more complex. But essentially, the input layer has to be clear, the output layer has to be clear. And the RAGs works in between to help come up with specific orders. This is the broad AI model. Next slide, please. This is the actual fully integrated clinical healthcare integrated management system that we installed in Hyderabad. I'm reporting this with the consent of the managing director of the company, which has since been sold, right? You will realize that there are a lot of elements that have to be integrated. I won't go into it again because the idea is not to talk about how the system works. Next slide, please. This is the broad system. We called it HECA. And what it does is, for the value delivery of healthcare, it has to link all of this in a network. 6 years ago, when we did it, there was no 5G or 4G, but we did manage. And the point was very simple. A patient called the call center, where the qualified person directed him to the clinic, accredited clinic, who gave him help from the pharmacy. Immediately, if it was say 11 o'clock at night, he got some medication. Next morning, an appointment was fixed. He went there. His medical records were taken, so on and so forth. And then he went in for surgery or medical thing or whatever it was. It's a fairly simple system, right? Next one. But I'm going to run through this very fast. Just run through the next few slides, please. Yeah. Next one. Yeah. Those mind maps were actually what we did about how it has to be connected, that intermediate layer which I spoke about. And then we ended up with a system which does all of this. It handles the pharmacy, it handles the labs, it handles the radiology, it handles the primary care unit. We had a patient portal where we push the data into the eyes of the patient, including learning and teaching and telling him, look, you have a cardiac condition of like this. These are all the newest articles, newest drugs. Get yourself informed, right? This is working, but in a very limited fashion after 5 years in Hyderabad. Next slide, please. Right, this is Singapore. Singapore has been struggling with networking for the last 15 years, and they've spent millions of dollars that I know of. And basically, the clinics, the hospitals, and the private practitioners are all linked, and being a very small island and fairly advanced in terms of its internet speeds, it was fairly difficult to, not so difficult to get the health records. Next slide, please. But you see, they had eight hospitals and 10 private clinics to integrate, which won't happen even in one district in any of our countries. So they did it, and they struggled enormously with this. I know they had multiple consultants. None of them could really deliver. So we are talking about a very complex system, and what makes it complex? Next slide, please. Right. This is for image reading into an EMR where AI is used. Next one, please. This is the simple thing about India, where we have had so many different attributes that the primary healthcare center has to work. And let us face it, the bottom of the pyramid that I showed, 80% of the population is going, the first point of contact is one form of the primary healthcare center, and that is pathetic. Now, when you relate it to governance, there is no accountability. Money comes, money goes, people die, children are born. And I can tell you in Kunur, when we did some work with an NGO, with a public health center, children were being delivered without hot water in the middle of winter, right? The mothers who came from tribal areas had no clothes to wear. This was how pathetic it was, because we did whatever we could. There is no transparency. There is no data flow, which is vital for technology. And there are no good management practices. It's, if at all anything, it is hospitals don't want to share information and so on and so forth, which I'll come to. Next one, please. So this, what do I see as the governance challenges? Standardization of data collection. I believe the ABDM has started it, but they've done less than 500,000 people in hospitals. But the hospitals are not willing to co-opt because it requires interoperability of IT, ITs, medical equipment, software, database across systems. All this has to be normative. It will not work if you give liberty and independence. Continuous American standards do require a certain amount of standardization of the forms they fill and how they report. Continuous information feeds on disease, cures, endemics. The point is many of our rural health centers are not connected by internet and they're inaccessible. In fact, one of my friends here won a national award for making a, what do you call it, an ambulance with an auto rickshaw. Privacy, security, and confidentiality, and establish ownership of records. Hospitals refuse to share records. You can't get a second opinion. And it is quite pathetic because the records are mine, not to the hospital. So these are the challenges. You can have a lot of technology, but unless we overcome this, we are not going to move forward. Next slide, please. Right. See, there are a plethora of schemes. I've not gone into each one in detail, but let's focus on the National Health Mission and the Ayushman Bharat Yojana. These are trying to be normative in the data. If we can integrate this data collection, then that input that the AI was looking for on the left-hand side is very easily accessible. Therefore, we can give an output and we can design the engines that work in the AI model between large learning models and RAGs and algorithmic models as relevant to deliver a vital service to healthcare. But I don't know the status. I have to investigate whether all these can be integrated, if at all, whether Ayurveda, homeopath, Unani, Ayush schemes can integrate with the allopathic schemes and so on and so forth in terms of reporting. But that is a huge challenge that we face. Next slide, please. This is the screen, ABDM screen. You can see the numbers. There are about 18 crore people whose health records are available. You can go and fill up your own record and manage it. Then when you fill up your own record, how reliable is it? Right? So in other words, there are systems to create digital highways in the healthcare ecosystem that the government is working on. And I'm sure given the sort of facilities that AI can deliver today, which we didn't have 3-4 years ago, we can really deliver a technology-based domain, but there's a lot of work ahead of us and a lot of acceptance that democracy may not necessarily be the way forward in data collection and storage. Next slide, please. It's a simple example of how to get data from a village. So you can imagine if I have 650,000 villages, how I'm going to collect this data, how I'm going to standardize it, and how I'm going to integrate it. Next slide, please. Right. The idea was to give a snapshot of what I thought was the current scene. Mukul, other participants, if you wish to query me, I'd be happy to share. If not, we'll go through the panel and can address the questions when relevant. Thank you.
Yeah, I think we can have Q&A if people want to.
Yes, thank you so much, sir, for such a wonderful session. Mukul, sir, would you like to add your comments on this?
No, this was a very clear presentation, and it lays down the challenges in adopting AI technology in healthcare. So it reinforces what we have been saying, that healthcare governance and management is complex. Technologies are now available, but they don't become available without investment, without changes, and so on. So this is where the focus will need to be. And the talking in very large generalizations about healthcare, health for all and all that, It's not very helpful.
Okay, thank you so much, sir, for your comments. Now the floor is open for the questions. Participants can kindly put your questions in the quick Q&A box or they can ask it directly. Okay, so let's move forward.
I think we have a question from Lakshmi ji in the Q&A.
Lakshmi ji, would you like to ask it? Okay, I'll read it out. Could you please give some examples of why things did not work out in Hyderabad with this new model?
We were basically a Chennai-centered company. The Hyderabad group called Call Health, it worked there. It worked well, but takeoff is slow. The challenge is to accredit just not hospitals. We have to accredit hospitals, we have to accredit doctors, we have to accredit pharmacies, we have got to have the call center people trained in recognizing the symptoms, because a symptom could be the same if you're going to have a heart attack, if you're going to have a bad stomach or a stroke coming along, right? So accreditation was a challenge because, and in a large city like Hyderabad, you need to have a pharmacy or a doctor within a few kilometers of the patient, right? And the pharmacies were willing, but then they had to deliver medicines at 2 o'clock in the morning on a motorbike to the patient. That was a challenge, right? Second thing was standardization of data. No two hospitals wanted to have the same standards of reporting, right? Third thing was hospitals were not willing to share information for a second opinion. And I can tell you, at the Gangaram hospital, when we made the presentation, the ridiculous question was, if I see a patient and I think of what he's doing, you must come up with a prescription. That is how low level the understanding of technology was. Now, in this system, you could input the symptoms on a tablet. It compared it with an almanac and gave out a prescription with lots of adequate cautions. Directly sent the request for imaging or for blood test or for the pharmacy. The pharmacy is a den of corruption. Why? Obsolete medicines are not taken back by the suppliers, and they work hand in hand with the pharmacist to sell it off at discounted prices. These are real issues. So we had a very elegant FIFO-based system based on obsolescence and billing and all those relationships. It didn't work. Third, when we went into the operation theater, for every surgery, you have a bill of material for what has to be bought. If you bought it in the pharmacy, it was more expensive. So people would go out, buy it and bring it. Imaging. All doctors, less than 60% of the doctors were using the in-house specialty for imaging. They prefer to farm it out so that they could make their own returns on it. So these are all very fundamental issues that we are facing. And unless we have these resolved, it is not going to work. That time, just changing large MRI and other things, we had to go to a portal and do it. But given today's internet speeds, we can do it directly with the patient. But then the hospital has to agree to share it with the patient. And lastly, insurance companies prefer to have it in OCX because they'll have proof. Here, the system was completely downloadable in a PDF file, and they could process it. And the point is, if you downloaded it on file with all the required checks and balances, is this allowable under this insurance law, that insurance law? They had no room to negotiate, right? So it became a challenge at almost every front. The only thing that worked well was the Practo registration system. Now, that's the least of the problems for us to manage. And anyway, the people in the tribal areas are not being registered on Practo. So there's a combination of factors that limited its utility. And lastly, no hospital was willing to make an investment in this. Everybody thought it was a cost center. And other than Hyderabad, after 13 years, we were not able to convince one hospital to buy this system, though in the US, several hundred clinics bought this and started doing very well with it, right? So that's the broad summary of why things fail, and these are also indicative. You can have fantastic AI, but if you don't have all these issues resolved, you're not going forward anywhere.
Yeah. Thank you so much, sir, and thank you so much, Lakshmi ji. Ashlesha ji, would you like to ask something? Okay, I'll read it out. What is the role of AI for CHWs in public health in Singapore?
I'm not familiar with AI, what has happened in Singapore. I'm going next month to get myself updated, right? Essentially, long before AI, they were able to standardize a lot of procedures. As I told you, there are only some 8 government hospitals and 10 private large hospitals and about 800 medical practitioners. And Singapore, the law is clear. If you don't accept what guidance we are giving you, your license is pulled. So they were able to get data. How able they were able to process it. Now also remember one thing. Advantage in India is a doctor sees in one day what a physician in Singapore would see in 1 month. So the volume of data that you have access to is limited. And in AI, if your data set is limited, you can go into all sorts of loops, which is what RAGs limits. So they don't have that volume of database that required AI, but they tried very hard. I don't know what the current status is, but maybe in a couple of months, I would have understood it. I'm spending a week in Singapore to understand it.
Okay, thank you so much, sir, and thank you so much, Ashlesha ji. And sir, thank you so much for joining us today, and we are really grateful to have you here. And thank you for your such an informative session. We got to learn a lot from this. So we'll move forward with this. Now it's my honor to invite Dr. Parashram Patil ji, Senior Advisor, Maharashtra Institution for Transformation, Niti Aayog, Agriculture Economist, Prime Minister's Museum and Library Fellow, New Delhi, Senior Visiting Fellow, IMPRI, for his session. A warm welcome to you, sir.
Thank you. Thank you. Can you hear me properly?
Yes, sir. Yes, sir.
Thank you. Thank you very much. So, good evening, all of you. And it's such wonderful to see the professor's lecture on the healthcare. So, thank you, sir, for enlightening us. I'm not a health expert. I'm going to talk the food and health in terms of agriculture. How agriculture can contribute in terms of having a good, healthy life. What is the status now? And what are the challenges we are in this sector facing, which is very crucial in terms of achieving the food sustainability. Now, right now, if you see the Indian agriculture, it's changing. It's changing in terms of the production agriculture to the industrial agriculture. So our food, availability of food is also changing from the traditional food system towards the industrial food system. Let me give an example, and we'll understand. For example, in 1970s, we had a green revolutions. We had a green revolution. It is because we just wanted to available food for everyone. Because food was not that at that time sufficient, so we wanted to make the food available to everyone. So our entire food system was based on cereals, especially in terms of paddy and in terms of rice. Still that continue. And if you see, if you consume only the paddy and the rice, wheat, then definitely is going to have a certain kind of deficiency in our food system, in our body, in terms of nutritionality. That's why we need a very diet kind of food system, diet kind of food balance. We need horticulture crops also. We need meat also, not only the rice and wheat. So right now, if you see, India is struggling in terms of nutritionality. We have enough food, but whether that food is nutritionally sufficient available with us. For example, in India, we have a lot of deficiency of iron and zinc. In India, we have lot of deficiency of vitamin C. So the availability of food, we have to see in terms of whatever food and nutrition we want, whether that is available or not. I think that is the problem. For example, if our income increase, then our food intake is not like that. We are going to have a more rice or more chapati or more wheat. We need a nutritional food, like we need horticulture crops, horticulture foods. We need a meat. We need a milk. So that is the way that we have to see our entire agriculture system in terms of availability of food, whether that availability of food is catering those things which we need in terms of nutritionality. For example, when we talk about sustainable food system, when we talk about good food for good health, we also have to say what is the source of that. For example, right now, our entire agriculture is depend on chemical fertilizer, depend on chemical pesticides. So that entire things comes to in our plate. That entire things comes through our foods to in our body. For example, in Punjab, due to the green revolutions, we have huge excess amount of pesticides and fertilizers. And the land of Punjab is become a slowly become a desertifications. If you see the pH level, or if you see the carbon availability or organic carbon into the land, we should have at least 2.5% carbon to that land should be the productivity. If you see the Punjab status now, it's just 0.5%. So this all stuff in terms of chemical fertilizer, all stuff in terms of the pesticides, everything comes to your food and that comes to your body. Right now, so Punjab is in, not only in desertification, it's also on the verge of the health disaster. There is a one trend every day going from the Punjab to the Delhi. It's called a cancer patient, cancer trend, cancer express. Same with the Maharashtra. In Maharashtra, there is one called Tahsil called Shirol. It is in Kolhapur. From there also, that Shirol is become a cancer capital in the state. The reason is that this excess amount of use of chemical fertilizer, excess amount of use of the chemical pesticides that comes to your vegetables, that comes to your paddy, that comes to your other food items and comes to your body. Now, what is the solutions? So we see the government of India at the state level and at the national level, it's working in a very different way. For example, now we are talking about having a organic food system. Now we are talking about the organic food system. Now we are talking about using the biofertilizer. Now we are talking about using the biopesticides. Now we are talking about having the natural farming. Now we are talking about the zero-waste farming. The larger perspective is that the availability of food, it should be sustainable in terms of health-wise, sustainable in terms of nutrition-wise, and sustainable in terms of, it should be available to everyone. If our food system is not correct, then definitely this is going to impact on our health. For example, now we are talking about the biofortifications because we have we deficiency in iron, we deficiency in zinc. Can we do or can we fulfill the deficiency by going for biofortification of foods? So these all sorts of things that we have to think in terms of larger perspective. Now the country like India, which is facing a huge issue in nutritionality, it is because the food consumption system. Our food consumption system is largely depends on the rice and wheat. We are very less thinking about having a horticulture. For example, give my own example. I am a farmer. In my farm, in my village, we grow 10 kind of crops. For example, we with the rice, we cultivate the millet, we cultivate the sugarcane, we cultivate the cashew, we cultivate the chilies. But in our day-to-day consumption, of food consumption, in our plate, maximum concentrate is of the rice chapati and rice, regular rice. But also I grow almost 10 tons of cashew nut, but which I don't eat it because we feel that that awareness is still not with us, that this rice and chapati is not sufficient. We also used to have all the nutrition things. So that is the case, not in India, it is everywhere, especially in all the developing countries. So that's why we have to see availability of food should be there in terms of the nutritionality, in terms of the dietary things, and also we have to see the source of it. Why the organic farming in India is getting momentum? Why the organic food is getting momentum? Why India is still now India is the capital of the organic productions. India is almost #1 in the organic export. It is because of that only that our food has to be nutrition well, because that is going to impact on our health. For example, I will give the classic case in the COVID. India is the largest producer of spices in the world. 80% spices of the world we produce. In the COVID, India's export of spices has been grown almost by 34 to 50%. And especially from the European people. And when we analyze the reason is that the spices is very effective, very nutritious in terms of fighting against the COVID. They build your in boosting power. So like that, we have to see our entire food consumptions, entire food pattern, entire agriculture practices towards the health. It is not only of the now we have achieved the status. We don't want to just produce. We have to see whatever we produce in terms of horticulture, in terms of spices, in terms of nutritionality, even in terms of the fisheries. India has a 7,500 kilometer of fisheries coastal line. India has the highest amount of populations of the animal feeds. So our diet should be balanced. So our agriculture has to be in that way. So that's why I just wanted to find the nexus between the agriculture and health. Our agriculture, food, and health has a nexus. That nexus we have to identify, and we have to see whatever we are consuming, from where it is coming, how that practice is going on, and whether whatever our body is required, because India is a bless, because all kind of nutritional agricultural stuffs we can produce in India. Only issue is that are that reaching to your plate or not. If we solve that problem, then I think the problems of nutritionality in India, food consumption system in India is going to solve. So that's what I wanted to just identify the nexus between. I just wanted to explore the nexus between the food, agriculture, and its impact on health. So thank you. This is from my side.
Yeah, thank you so much, sir, for such an informative session. Yes, Ranjan Das, sir, you can go ahead.
Thank you very much. Dr. Patil has given a very excellent overview of the connection between agriculture, food, and health. There are 3 points I would like to highlight here. One of the points which our mainstream medical scientists as well as agricultural scientists, we have not been able to bring out very clearly is that the land has been utilized for thousands of years, maybe more than thousands of years, 5,000, 10,000 years, for agricultural purposes. Now we know there is a about 124 or some new elements which goes into the production of anything, including agriculture. So now when a particular crop is cultivated in the same land and it is extracting the same nutrients, it is very likely that it will be depleted in those particular nutrients. So the land is depleted. Naturally, the agricultural produce will also be deficient in those particular nutrients. We have to understand that. And naturally, the nutrient repletion first of all has to be done for the land. Only then we can get the nutrients from the particular issue. Particular crop. The second point is our laws regarding agricultural practices are also very, very rudimentary. For example, in the West, there are very clear-cut regulations when to spray insecticides and pesticides before harvesting of a crop. So no pesticide can be sprayed at least 14 days or 2 weeks. I am not an agricultural expert, but yes, I am a nutritional expert. and I have to be little aware of some of the broad rules and regulations. In India, no rules and regulations exist, or if they are probably very less implemented. So that makes us the very good example that Dr. Patil has just mentioned, that Punjab is a cancer capital, if we speak of the state, and some of the districts, and there are many other places where cancer prevalence is very high, and they are very directly related to the use of pesticides and chemical insecticides and fertilizers also. The third point that I was wanted to mention here is, there is a simple method of how we can get most of the nutrients that we require in our food, and that we call as the plate method. In that plate method, it is pictorially depictable, where the cereals are formed at the base of the pyramid, and then we have got very clear cut demarcation. So 40% of our things have to be through the fruits and vegetables. The very minimal amount of consumption of the processed foods, particularly the sugars and anything that is white, the refined flours and cholesterol rich oils, they have to be very minimal. So if we can follow this plate method or a pyramid method of food, if we can make the public aware of these, then probably much of the issues will be sorted out and we will be getting all our nutrients. So with that small overview, I will just pass on to the other panelists and my other colleagues. Thank you, Tanu, and thank you, Dr. Patil.
Mukul, I have some experiences I'd like to share. I think Dr. Das
and
Dr. Patil have given us a broad sweep. May I go ahead, or would you?
Yes, no, you go ahead, please.
Firstly,
go ahead.
I agree. I follow the plate method, Dr. Das. I was taught this by Dr. Tripathi of the Freedom from Diabetes movement.
Yes.
And as a doctor, as a person in nutrition, you will understand that my liver function improved, my diabetes vanished. It came back for other reasons. And I very rigidly adhere to it, and I would endorse it. I take about 40% of my every meal. I eat only twice a day, and both meals, raw fiber is the major content.
Yes.
But I'm going to be a bit meandering here. Milk has been used as a wonder nutrition. Rice and wheat have been promoted, as Dr. Patil pointed out. Both these combined have made us the diabetes capital of the world. For those who are interested, milk has an insulin-like growth factor, which is very detrimental and is the cause of bulk of our diabetes. And what people don't know is 30 grams of curd, and coming from a curd eating community, adds 1 gram of body weight on a linear basis. We have used milk as a substitute, and that is enormously harmful, especially when we agree that the primary thing is not healthcare in a hospital. The primary thing is wellness at home, so that the need to visit a hospital is less. Lastly, for the last 11 years, I've been doing organic farming in my little plot in the hills. It is a tea garden. The pH was 4.5. I have now moved it to a pH of around 6.8, 6.9. And it took me about 4 years, 5 years of using only desi cow dung and making my own compost, making my own biodynamic compost, vermicompost. And today I can say my yields, for example, my strawberries that I grow, well, the average weight of a strawberry in India is around 23 grams. Mine comes at 45 grams. And the yields are very good. The most important thing, most critical thing is the transition from chemically based tea gardening to organic farming. The pest level has dropped. I can tell you in the last 2 years, only a day before, because they were spraying some pesticides in the neighboring area, all the aphids migrated. Of course, I detected them and I corrected them. And the best correction is again not a chemicalizer, a fertilizer. It is just fresh castor oil with liquid soap, which does the correction. And the point is, everybody talks glibly about organic soils without realizing that the amount of compost that you have to generate is enormous. This has to be done. I was part of an NGO. We taught people rotation farming, how to do the crop rotations, how to use nitrogen fixation, how to use the Navadanya. All this is established. In Punjab is a very peculiar problem. every fertilizer that you use has 45% of additives, junk, and they've choked the soil. Hence, they have to go on adding extra fertilizers and extra nutrients on an ongoing basis. There is a superb Vedic method of correction, and if anybody is interested, if you send me, I will send you I have compiled it for regenerating soils. And what I do know is, once you get organic, the health of the soil is such that you don't need fertilizers. I probably apply the pesticides once a year, particularly during the summer when the nesting, I mean, what do you call it? The eggs of the pests. And let's face it, there's only 3% of the pests are harmful. The rest of it is immaterial and very easily doable, because whether you use the Panchakavya or you use the alternatives to that, cheaper alternatives to that, all this knowledge rests in our villages. There's no need to do anything. And to make compost is a trivial process. I can tell you, once you demonstrate how easily it is to be done, you'll be surprised how much further we can go. So those are my experiences, and I hope it adds to the nuggets in this conversation. Thank you.
Yes, very much, Ram. Thank you.
Thank you so much, sir, for adding. Yes, sir. Yes, sir. Mukul, sir, continue.
Are there any questions for Dr. Patil?
Sir, can I ask a question actually, because there are a lot of discussion on nutrition and farming.
Yes,
okay.
please.
Before that, I just want to give my background. I think some 8 years back there was a project from the Department of Biotechnology on development of insect resistant brinjal, basically BT brinjal, right? So I was one of the team member in that project actually. So I was doing my PhD at UAS Dharwad, okay, and my professor was one of the PA in the project, and we were developing these strains of BT brinjal basically. Basically, the gene was given by Mahiko, okay, and we were trying to insert that genes into the identified local varieties and trying to find out how they perform in the field level basically, right? So we did extensive research, for almost 4 years on this particular project. Okay, field trials, multi-location trials, etc. And we have literally observed that brinjal is one of the highest vegetable that is sprayed with pesticides basically. Okay, so we have literally found out that the pesticide usage was reduced by almost 60 to 70% by using BT gene. Okay, this gene is naturally present in the soil. Okay, so that's how we found out that slight genetic modifications which are within the nature, we can improve the nutritional quantity and make them less harmful at the end of the day to the larger insects as well as for the humans. Okay, so this is one thing which I wanted to add here. The government should also look at I'm sure that I have due respect to the organic, because I do practice in my village, but at the same time to keep the interest of larger the country, I think we need advanced methods to enhance the productivity with the limited resources. I think policy level changes that needs to be required in this particular aspect. Yeah, thank you.
Thank you so much,
Dr.
sir, for
Omkar.
adding comments. Mukul, sir, would you like to give some kind comments on the session?
Yeah, this is I was hoping that we will get a robust discussion and comments, which we have received. And again, we emphasize that knowledge, local context-specific knowledge, is extremely important. Scientific principles are global. Technology is local. And to try to do the kind of work Dr. Omkar has done, or what Ram has been experimenting with, what Dr. Das has told us about the possibilities as to how we can look at the linkages between agriculture, food, and health and so on. These are very much integral part of any healthcare system that usually are neglected. Sorry. Can you hear me?
Yeah.
What
Yes, sir.
we are giving up our healthy food habits or unthinkingly eating what is thought to be fashionable and so on. How to do that education part? And this has to be done at a more decentralized local level. So we do need local champions and so on to try to be a part of improving the health status of the country.
Mukul, just a
That was
comment here.
precisely the idea.
There is a tendency, the government of India is promoting millets, which was our
Yes,
traditional breadbasket long before rice
that's
came on
right.
this. But
That's right.
I use a lot of millets. It helps, but we need to also understand that several millets are very high glycemic index. For example, rice. We need to understand that most millets are deficient in iodine, which can lead to thyroid issues. Right? These are not very comprehensively defined. And what is very sad is when you go shopping for vegetables in the hills here, family will buy 5 kilos of rice and 2 kilos of dal and 1 tomato, 1 onion, and 1 potato.
Yeah.
Right? Which hardly gives you the sort of nutrition that you need. Right? Of course, don't talk about meat or eggs because that's hardly a major constituent in these parts. Right? And the last comment I'd like to make is organic farming is not about farming. Organic farming is about nurturing the soil to nurture the plant. That takes time. And all studies in USA, Australia, and New Zealand show that the first 3-4 years, the yield drops. In the US, the average yield increase after 5 years is 116%. Right? And a lot of it is happening, but people are not focusing on the soil health in terms of how they should take it organic. And all that it requires is cow dung and cow urine with a little bit of, what do you call it? I'm just thinking about the Tamil word for it, but not gehu, the whatever it is, that yellow stuff which we use for making bondas and bhajis, right? So very easily doable. I have demonstrated it here. Many people have come and had a look, but not many are willing to spend the time. They don't want to wait 4 years because then their livelihood based upon 10 cents of land, they don't get enough to service it. And in organic, many traditional English crops like carrots and tomatoes don't thrive too well, which is again part of our staple diet.
What all the discussion also shows is anybody who wants to be in and talk about health policies and so on requires to have lot of knowledge in many different areas and lot of humility. Simplistic kind of statements, generalizations are to be avoided, and we all need to be much humbler about making progress and understanding health policy and governance.
Again, sorry to keep interrupting, Mukul. Basing on local knowledge, India has 7 systems of composting.
Yeah.
Right, each specific to the region. There's the Nagpur school, there's a Coimbatore school, and in Maharashtra there are a couple of other schools. Knowledge on all this is available extensively on the net. Very extensively. And I've learned bulk of it from length. So some very good friends who are very experienced in it have guided me and helped me out. But I don't think it's a dearth of knowledge. There's plenty out there, but it has to be channeled and collated so that it reaches the people whom it matters. But definitely one thing for the government of India, I would say, don't push milk, don't push millets. beyond a certain reasonable limit. Milk is very harmful, and the 5 white poisons that Dr. Das mentioned, Ayurveda, milk is the first. Milk is the first, and I've experimented with it.
We have one more presentation, right? So can we complete that in the next 5 to 10 minutes?
Yes, sir. We are just left with the question part only. So, Parashram, sir, would you like to take up one question?
Yeah, sure. Q&A comes first.
Yeah. So, Parashram, sir.
Is it not online?
Okay. So, the floor is now open for the questions from the session of Manorama ma'am as well. The participants can ask their questions.
Okay, let's check the question which we have.
So we have got one question from Lakshmi ji. Could you reflect on the reducing economic access to diversified foods beyond cereal, such as meat and milk and fruits, that people are facing in today's context? Okay, maybe sir is not here.
Who is the question directed to?
So Parashram, sir.
If the chair permits, I can answer that.
Yeah,
Sure,
please.
sir, sure.
So the first and foremost thing is that we need to, the simple principle of food is that take a variety of foods, the first, and make it as colorful as possible, the second principle. And the third principle I have mentioned, the land has to be rejuvenated first, and traditional foods. Interestingly, if you see, potato came to us from after Columbus discovered South America. The entire Solanacea family was not present in our continent, the Indian subcontinent. So we got tobacco, we got the tomato, we got the potato, we got the chilies through after Columbus discovered South America. Now, as soon as the potato came, it was a cheap source of food, no doubt. The famines were almost done away with because potato was cheap. If we think of just 2 decades back, it was coming at less than the cost what cereals usually costed. And that became one of the staples that helped in doing away with malnutrition, but certainly that added to the lack of diversity of food. Potatoes are similar to cereals when we look into the nutrient values, and they do not have any color, they do not have much of the nutrients except a small amount of vitamin C. So the simple traditional thing is that we should have traditional foods as far as possible, minimum amount of processed foods. Another point what I would like to mention here is if you look into the internet and if you search for blue zone communities. So blue zone communities are about 5 or 6 communities across the globe. They usually live in high altitude landscapes, usually 2200 meters above sea level. And they also have got an average life expectancies of 100 plus years. So they particularly, their food habits are, they do not have any processed foods. They consume only locally grown, organically grown foods. One of the things. The second thing is that they do not have any hurried lifestyle. They are usually non-industrial economies. They follow traditional lifestyles. They believe in something which is superior, superhuman. So 4 or 5 principles, they set us apart from the other industrialized or developing economies. So if we are actually looking for healthy lifestyles, healthy populations, and healthy policies, we need to look into these aspects also. Our health policy managers have to be aware of these things, that there are some things which are known as blue zone communities. that there are something of land rejuvenation, and of course we will have to make a good blend of these with the modern systems that we have, what was being mentioned little while ago regarding the artificial intelligence. There is a very good small example of what Dr. Ramakrishnan was mentioning in Chennai itself. The entire Tamil Nadu, and particularly the Chennai center, they have set up a very good artificial intelligence system of linking and patients seeking emergency healthcare being transported through an ambulance to a hospital where beds are available. So this is being done through a third-party agency. Particularly, it is known as Hindustan Latex Liver Life Care Limited. HLL is one of the components, and if I remember correctly, the authorities, public health authorities of the Tamil Nadu Health Corporation. Coming to the second aspect regarding the NABH accreditation, before we go for NABH accreditation, certainly that is on the cards, that is already being looked after by the Quality Council of India. And when I was the Deputy Director General, I was also at the central level at Nirman Bhavan, headquarters of the Health Ministry. So we have got an act which is known as the Clinical Establishment Act at the central level. Their counterparts, health being a state subject, in fact, each of the states was expected to enact their own respective state clinical establishment act, and I think about 12 of the states have enacted them and are actually implementing them. But then even those are very rudimentary. So each of our states and union territories have to have their clinical establishment acts, implement it properly. That would also be beginning of the baby steps, which will probably address to what Dr. Manorama Bakshi was mentioning, that our proportion of medical value tourism is very less. Within the Asian region also, we are probably the third, although economically we are very high up. So this Clinical Establishment Act will address many of the risks in the hospital and the transportation issues. Recently, I had gone to the Land Border Authority of India just 2 days back, along with the ministry high-level delegation. In fact, this Petra Pole, the border of Bangladesh and India, this is also the India's, not only India's, but entire globe's highest footfall across an international border. 30 lakhs each year. That makes in between 7,000 to 12,000 footfalls each year, an exchange of 500 trucks. So there they have got a facilitation counter. They call it the Medical Value Tourism Facilitation Counter of the LPAI. LPAI stands for Land Port Authority of India, which is under the Ministry of Home Affairs. And this manages all the land borders that we have with all the countries, including the Atari border on the west. On the east, of course, Petra Pole is the single highest, giving us 70% of our entire commercial trade with Bangladesh, and also the similar proportion of the footfalls that we have. Majority of which is for the medical tourism, rather medical value tourism, now we call it. So with that, I would hand over. I have exceeded the time, but I thought that is important to share with our colleagues here. Thank you very much for giving this opportunity.
Thank you so much, sir, for answering the question so comprehensively. And Lakshmi ji, I hope the question got answered. Do we have any other questions? Okay, so we'll end this program. So, as we come to the end of day 3 of Healthcare Sector Management and Governance, an Indian Perspective, an online national summer school program, a 1-month immersive online certificate training course, I, Tanu Paliwal, researcher, IMPRI, Impact and Policy Research Institute, would like to propose the formal vote of thanks on behalf of IMPRI, Center for the Study of Finance and Economics, IMPRI Web Policy Learning, New Delhi. We are grateful to our expert for day 3, Professor Mukul ji, Dr. Manorama Bakshi ji, Mr. Parashram Patil ji, and Dr. V. Ramakrishnan ji for taking out your valuable time and giving an opportunity to the participants to learn from this online certificate course. We thank all of our participants who have actively participated in today's deliberation. Readings of the session have been shared in your email, and a video of the session will also be shared with you for learning. We look forward to welcoming you for our last day of the certification course on 13 July at 6:30 p.m. We are grateful if you're watching us on YouTube or listening to us on our podcasts or reading our publications. We hope you continue to join in future to our IMPRI Web Policy Talk and Web Policy Learning. Wishing you all a very good evening and thank you.
Thank you and good night.
Thank you and good night.
Thank you, sir. Thank you, ma'am.
Thank you.
Thank you.
Thank you, Mukul.
Thank you. Namaskar.
Namaskar.